Hi everyone, I am Francesca Cerutti, Gold Member of Style Italiano Endodontics, and it is my pleasure to welcome you to this webinar done in collaboration with Fanta Dental. The topic of the webinar is root canal filling. I prepared a video, so I would like to watch it with you. And please remember that if you have any questions, you can write them and I will answer at the end of the video. So enjoy! Hi everyone, I am Francesca Cerutti, Gold Member of Style Italiano Endodontics. Today my topic will be root canal filling, and I would like you to dive into root canal filling in order to completely understand the importance of this passage for the outcome of root canal therapy. Why do I say so? Because a recent review by Chiara Pirani and Josette Camilleri stated that 40 to 60% of failures of endodontic therapy is due to the quality of the root canal obturation. And so, if the obturation is non-satisfactory, we are extremely likely to have a failure. And so why is root canal filling so important? Because we don't want to have our tooth contaminated by bacteria and microorganisms in general. And so what do we have to do? Textbooks are extremely clear about what we are supposed to do as endodontists, because they say that first of all, we have to shape the root canal system. And why do we shape? We shape because we need to remove the pulp, the bacteria, all the remnants of tissue that are inside of the root canal system. And modern endodontics allows us now doing these steps in a very short time and allows us being extremely respectful of the original anatomy of the root canal system, because nickel titanium files that are available in a variety of sizes and designs and heat treatment, etc. But this is not the topic of our lecture. These files allow us being extremely conservative and fast and effective in the phase of shaping the root canal system. But we also know that no matter which kind of file we choose, still a consistent part of the root canal walls will remain untouched by our files. And so we have to rely on something different. We have to rely on the chemical action of the irrigants against the pulp tissue, the bacteria, and the inorganic component that will be inside of the root canal, the smear layer, for example. And so we have to be as dedicated and as precise as possible to the phase of cleaning, because this is the moment in which we get rid of the microorganism that could be able to cause an endodontic infection, apical periodontitis, etc. And so they could play a role in failure of our root canal therapy, even if our shaping was perfect. But it's not enough, because we have to fill adequately the root canal system. So what is the aim of our filling? We want to stop the communications between endodontium and periodontium, and so we want to block the apical foramina, the lateral canal, the dentinal tubules, etc. And what else do we want to do? When we try to provide an hermetic seal of our root canal system, we also help intubing those bacteria or those irritants that our shaping and cleaning phases were not able to remove completely. And also, we avoid the communication between endodontium and periodontium, because we saw that when we have an endodontic lesion, then we can have a secondary involvement of the periodontal tissue. And in the same way, a primary periodontal lesion can have a secondary endodontic involvement. And so we would like to keep endodontium and periodontium separate as much as possible. And last but not least, we want to prevent the reinfection, because we cannot achieve a sterility of the root canal system. And so we want to create a barrier, something that will not allow the bacteria to come inside again and reinfect the root canal system and the tooth. But what does the literature say about the influence of the extent of the obturation of the endodontic system on the outcome of the root canal therapy? Well, they say what we expected by knowing the article by Pirani and Camilleri. So the extent of the obturation is influencing the outcome of the root canal therapy. Whether it is over or under extended, a bad obturation involves an increase in the risk of failure of the therapy. But when do we obturate? Because we have to obturate in the correct moment. We have to know the timing of our procedure. So first of all, we suppose that we were able to eradicate most of the bacteria from the inside of the root canal system, so after the cleaning phase. But after that, we also have to dry the root canal system. And once we are sure that the root canals are dry, then we can fill the root canal system. And something that we sometimes remember and sometimes don't as endodontists is that the root canal treatment finishes with a coronal restoration. And so if I place a temporary restoration on a tooth, this is not the end of my therapy. The end of my therapy will be the restoration, because coronal leakage is one of the main responsibles for bacterial reinfection of the root canal system. So I have to address it somehow. But how do I fill? Because there are several techniques, several ways to do it. First of all, I have to consider that my root canal filling is going to be in contact with organic tissues. And so, first of all, the materials that I choose will have to be as biocompatible as possible. And also, they should be stable in their size. I don't want something that expands too much or shrinks too much, because in one case or another, I would alter my initial filling. So I want something as stable as possible that is able to seal, because I don't want that there is a leakage, and after a short time I don't want my material to completely dissolve because it was in contact with tissue fluids. Because we have to remember that the oral cavity in general is a hostile environment for most of the materials that we have on the market, and so we have to find something that can resist in that particular environment and guarantee a long-term result of our therapy. And also, if possible, the material should be bactericidal or bacteriostatic at least, and radio-opaque, because we need to check the goodness of our root canal filling, so we have to be able to see it in the x-rays. And also, it has to have a good adhesion to the root canal dentine, because I want it to be as tight as possible and as close as possible to the canal walls. And also, I don't want it to stain, because one of the main problems of some classes of root canal filling materials that we used in the past was discoloration. We had teeth becoming red, becoming brown, becoming dark due to the chemical reaction of the filling materials with what was inside of the tooth. And so we don't want this anymore. And also, it has to allow us work peacefully. It has to allow us having a good timing to place our gutta-percha point inside of the root canal and to complete all of the procedures with no rush. I cannot have a material that is hardening and setting in 1 minute. I need something that allows me working with my timing. And also, I have to mix it easily. I cannot spend 20 minutes trying to mix a material. And last but not least, I have to be able to remove this material from the tooth in case I need to retreat. So it's a lot as a request for a single material. That's why we don't use a single material. The core of our root canal filling will be gutta-percha. Why gutta-percha? Because it's a material that is sensitive to heat, and so at 40 to 49 degrees it starts becoming soft, and then it is sticky and softer at 65 until it melts at 95-100 degrees Celsius. And so gutta-percha is a material that is composed in general by gutta-percha, zinc oxide, and sulfates, waxes, and resins, and the amount of these components is variable among the producers, but more or less 75% of our points are made by gutta-percha, which is derived from a plant, and all the rest is useful to stabilize it and to give her some antibacterial property, which is zinc oxide. What are the pros of gutta-percha? First of all, it is radio opaque, so I can see it very well in the x-rays, and it doesn't have huge variations in its size while subjected to heat and cold, so it's most of all dimensionally stable. It can be retreated because I can remove it mechanically, I can remove it with solvents, so it's a material that allows me retreating. But also, it is slightly bacteriostatic and it is easy to manipulate. It doesn't stain the tooth, and still it has a problem, which is it has no adhesive qualities. So gutta-percha alone will never adhere to the root canal dentine. But I can heat it. It has a good plasticity, and as I was saying before, starting from 40 degrees it starts becoming soft, and I can handle it in many different ways. And it becomes soft with heat, but when cooling it comes back to its hard state. So it comes back solid, stable material. And in many of the gutta-percha points that we find on the market, those by Fanta for example, have a top color who suggests the ISO size of the apical part of the gutta-percha point, in order for the clinician to make it easier to understand which point is compatible to the size of the shaping that we did. But I cannot use gutta-percha alone. I need something else. I need a root canal sealer that combines with gutta-percha and promotes the adhesion to the gutta-percha to the root canal walls. So it acts as a bond, as a link between these two components. I have very different types of sealers on the market because I start from the zinc oxide eugenol sealers, which are the most known and used products worldwide because they are available, they have no high cost, they are easy to mix, they have good qualities. But I also have different type of sealers, calcium hydroxide based sealers that are nice because they are antibacterial, they rise the pH, but on the other hand they have a big solubility problem. And then we have resin based sealers that have been considered as the gold standard for a long time because there are a lot of articles in the literature studying their properties, but still they have a problem that being resin based, their biocompatibility is not as high as the one of other types of sealers. And then we have glass ionomer based sealers, silicone based, and last but not least, bioceramic based sealers, which we will treat more in detail further. But what are the properties of an ideal sealer? First of all, it has to be tacky because it has to be able to attach to the root canal walls. And then it has to provide a hermetic seal because it has to adhere to the dentine and prevent the reinfection by bacteria. We know that gutta-percha alone cannot do it. We need the sealer to help sealing the space between gutta-percha and the tooth. And then it still has to be ready opaque because I need to check where it goes. And if possible, in the powder liquid formation, we want fine powder particles because this makes the sealer very easier to mix and it gives a smooth consistency. And also the stability. We wanted the stability from the gutta-percha, we also want the stability from the sealer. We don't want a sealer that shrinks or expands upon setting. And also, the same that we wanted from gutta-percha, we don't want the sealer to stain the tooth. If this product has some bacteriostatic or bactericidal properties, even better, because it will promote the periapical healing, for example. And it's the same kind of feature that we found for gutta-percha. We want a slow setting time. We want to have the time to work according to what we have to do, with no rush because the sealer is setting. And then it doesn't have to be soluble in tissue fluids, obviously, because I don't want to have a washout of my sealer. Obviously, it has to be biocompatible because it's going to be in contact directly with the periodontium. And last but not least, it has to be removable because if I have to retreat the tooth, I want to be able to remove also the sealer. But to do everything in life in a successful way, we need to master a technique because we have to know step by step what we have to do in order to do something properly. In general, in endodontics, we had two main categories of root canal filling, the cold and the warm techniques. The cold techniques were the lateral compaction of the gutta-percha and the single cone plus sealer, and you decide the type of sealer. As regards the warm techniques, we have the warm vertical compaction technique, the coneless technique or squirting technique, the name changes but the sense is the same, and the carrier-based techniques. What is the difference among these techniques? What are the pros and cons of every type of technique? But what about cold techniques? Why are they so widely used? Well, first of all, because they are kind of easy. There is a short learning curve, so almost everyone is going to be able to perform correctly one of these techniques with some training. And also, they are low cost because we don't need to buy several devices in order to be able to perform this kind of therapy. And if we manage them well, they can give good results. Also because they allow a controlled placement of the gutta percha. If we fit correctly our gutta percha point, it's extremely unlikely to have an extrusion, for example, because with a cold technique we are able to master correctly the apical extent of the obturation. On the other hand, with warm techniques, we have a higher quality filling because we're going to pack the gutta percha, which is going to adapt three-dimensionally to the root canal walls. So we have an increased possibility to go and fill anatomic intricacies, deltas, lateral canals. It has a good outcome in sealing all the port of exit of the tooth. But on the other hand, since I pack and heat and pack the gutta percha, my chances of having a over extension of my filling are higher, because I'm going to push the gutta percha point, and this means that if the tuck back was not perfect, if the cone fit was not perfect, I am going to extrude a little bit of my gutta percha point into the periodontium. Another thing, with warm techniques we use a very tiny amount, a small amount of sealer. And as I said before, we have a better adaptation to the anatomy of the tooth. A recent review from 2022 studied the effectiveness of root canal filling materials and techniques for treating the apical periodontitis. This is the review in which room I started the lecture. This is by Chiara Pirani and José Camilleri, and it's a very interesting read if you have the time. But there are also other reviews that were done more or less in the same period. So the articles that were considered in both studies are not particularly different. And what this article and the other article conclude, that in the end there is no clear superiority of a technique with respect to the other. So there is no superiority of the warm or the cold technique. They don't impact the treatment outcome. I mean that if a filling is performed correctly, whether it is lateral compaction, single cone, carrier base, warm vertical compaction of the gutta percha, the therapy is going to succeed, most probably. If the obturation is not performed correctly, our chances to fail increase. But no significant difference among the techniques. So how do I choose? What are the parameters that I take into consideration when I decide how to fill the root canal system? According to me, the first parameter is the anatomy of the tooth, the anatomy of the root canal system, because a straight root is going to be different to fill from a very curved root. It is going to be different to fill from a very thin one or calcified. So the anatomy of the tooth is what guides my shaping and also my filling. Another thing, how do I choose if I don't consider the final diameter of my preparation in the apex? If I have an apical diameter which is bigger than 50, 55, I'm not using gutta percha to fill the tooth. I'm using mineral trioxide aggregate. If, on the other hand, my preparation is thin, maybe I'm not fitting a heat plugger into that root canal. Maybe I'll prefer a cold technique, like a single cone with bioceramic sealer, for example. So another parameter to take into consideration is the apical diameter of the preparation. And another parameter, which seems stupid, but which is the armamentarium that I got? What do I want to buy to work or what does the practice in which I work give me to do my job? Because if I have everything, I can choose, I'm free. But if I don't have some of the tools that I need to perform a particular technique, how can I do it? So also tools are important. Talking about tools, Fanta developed a set of tools dedicated to the obturation. And the first that I want to show you is the heat heater, which is a heat carrier that is going to transfer heat to the gutta percha. It is nice because the tip rotates and you see the assembly is extremely easy. You choose the tip that you want and you just simply plug it into the hole that is on the top of the device. It takes it a very short time to reach the temperature because it arrives to the desired temperature of 200 degrees in 2 seconds. So it's extremely fast, because one thing that we as dentists hate, I think, is to wait for a device to be ready to use. And so, what do I have to do? I just press the button on the left to turn the device on. With the button on the right, I set the temperature that I want to deliver to the gutta percha. And then, if I touch the button of the left, the device is going to heat. It is going to work continuously for 5 seconds. Why it doesn't work continuously for more than 5 seconds? Because it is a protection for the periodontium. We don't want to overheat the root and transfer an excessive heat to the periodontium. That's why the device automatically stops. And then on the display you see the letters CD, cool down. The device tells you when it's cooling down and then you can use it again. Another thing about this device is that it has a quite appreciable standby time, so you don't have to turn it on continuously because it's just going in standby. And if you want, you can connect it wireless to a pedal, so if you prefer to activate it with your feet, you can do it. To disassemble it is extremely easy. You see that in the video I changed the tip and then I turn on the device again, I select the temperature that I want, so 110, 140, 170, 200, 230, and then I just have to press the button on the left to start the device. And when I start the device, the light turns on, and so it helps, if you use a microscope, to see what you are doing exactly. But the downpacking is not enough. We also have to backfill the root canal system if we want to use warm techniques. And so we also need the other part, the other device that allows us filling the root canal system, which is the e-filler. The e-filler is a device to extrude the warm gutta percha. How does it work? You choose which kind of needle you want according to the size of the needle and the length of the needle. You mount it on the body of the device and then you long press a button in order to turn the device on. You have to heat gutta percha. So there are these small cylinders of gutta percha that you can insert into the bottom part of the device, and then with the provided plunger you just go and push the gutta percha. It takes 14 seconds for the device to reach the temperature, which is not much, so if you are good with your timing, you can just avoid waiting. You turn the device on, you decide the temperature to which you want to heat your gutta percha, and then you put the sealer into the root canal, you do your downpacking, and when you have to do the backfilling, the device is perfectly ready and you just have to extrude the gutta percha. It can work at 6 different temperatures: 100, 120, 140, 170, 200 and 230 degrees. And still, as the other device, the e-heater, it has a good standby time. It is quite easy to use with your hands. There is no particular problem in keeping the device straight or in the correct position. It's a good ergonomy, and then you just have to press and the gutta-percha is going to be heated and is going to flow outside of the needle. So you put it into the root canal. And then what do you have to do? When you want to turn the device off, you just long press the button and you put it on its stand and it is ready to be used again. Another thing that I need if I want to do some of the techniques that I talked about is a plugger. But the problem is that we need different sizes of plugger because we have to adapt to different sizes of root canals. And so we have a series of pluggers that have one end in night-tie and one end in stainless steel. Obviously, the end in nickel titanium is smaller and the end in stainless steel is bigger. And these pluggers have isocolor, so we find the 3570, 4080, 51 and 06 1.2 millimeters. I was talking about different techniques according to the anatomy of the tooth and the apical diameter of the tooth. If I want to do an apical plug, because I need to fill a root canal in which the apex is 100, I cannot rely on gutta-percha and sealer, so I have to use mineral trioxide aggregate, MTA, or a bioceramic putty. So I put my increments of MTA, I pack it, and I'm done. And this is something in which I don't need gutta-percha, I just need a correct plugger for the MTA. If I'm using a single cone with bioceramic sealer, what do I have to do? I just put the bioceramic sealer into the root canal. I can do it in a couple of increments, I can do it all in one phase, it's the same. And then I put the gutta-percha point into the root canal up to the working length that I said before, and then I just have to cut the head of the gutta-percha point and I'm practically finished. If I want to use a carrier-based technique, then I have to deliver the root canal sealer into the root canal. Then I take the carrier, I heat it in the dedicated oven, and I deliver the carrier covered in gutta-percha to the root canal system. And I just fill it. And then I cut the head of the carrier, obviously. With this technique, it's easy to, for example, fill lateral anatomies or to go and negotiate the root canals in very thin and curved cases, for example. And then we have an evergreen, the vertical worm compaction, which is a technique in which I deliver the sealer into the root canal, as I've shown you before, or directly on the gutta-percha point, and then I take my heat plugger, I cut the head of the gutta-percha point, and then I heat the gutta-percha inside of the root canal, up to 4 millimeters from the apex. And then I take my plugger and pack. And as you can see from the video, I'm filling the lateral canals with gutta-percha and sealer, because this technique takes advantage of the fact that with heat, gutta-percha becomes plastic and it adapts to the shape of what is surrounding her, so in this case of the root canal. And this is the worm vertical compaction. But let's show some clinical case. For example, single cone and silicate-based sealer, which is something that is extremely trendy in dentistry at the moment. Why? Because in conservative preparation, it's perfect. Because sometimes my preparation is smaller than the taper of my heat plugger, for example. So what can I do? I cannot go and heat the gutta percha up to 4 millimeters from the working length. So there is no way for me to use a worn technique. For example, I'm using a single cone and silicate-based sealer technique. How do I do it? Step by step. First of all, I need to check the fit of my gutta percha point. This is something that we underestimate sometimes because maybe we use customized gutta percha points for the instrument that we use to shape, etc. But we also always have to check the gutta percha point fit, because, for example, if I just got distracted, I stayed too long with my shaping instrument at the apex and I went a little bit over my working length, the diameter of my apex will be different from the diameter of the instrument that I use. It will be bigger, and so maybe the gutta percha point is going to go over the apex. It's going to exceed the limit of my preparation, and so I always have to check the fit of the gutta percha point, and then I have to feel some resistance when I try to take it outside, the famous tag back. Then I dry with paper points the root canal system. How much do I dry? This is a nice question, but in general dry as much as possible the root canal system, because the latest studies say that even if you're using bioceramic sealers, you can still dry in a good way your root canal, and the bioceramic sealer is going to work good anyway. Then I deliver the sealer into the root canal. How do I do it? Many times the problem that we have with calcium silicate based sealers is the extrusion, the control of the extrusion, because companies tell us to completely fill the root canal with the sealer. There are some other techniques that have been developed later in which we just put the sealer in the middle and the coronal third of the root canal, and then we try to spread it with a thermofill carrier, with just the tip that we used, or with a gutta percha point, in order to reduce the amount of sealer inside of the root canal and in order to reduce the risk of extrusion of the sealer. And then when I have the sealer inside, I just arrive with my gutta percha point and I insert it up to the mark that I did when I checked its fit. And then the other thing that I have to do is to take my heat carrier and cut the part of the gutta percha point that extrudes from the root canal opening. And then, as a last thing, I just take a plugger and pack the gutta percha at the root canal opening. So this is a case in which I use the single cone and bioceramic sealer filler technique. You see I put the bioceramic sealer, I just put it in the coronal and in the middle third of the root canal. You see that I cut the tip that I'm using to deliver the sealer into the root canal, and then I can just move the tip up and down in order to spread a little the sealer. And then I take my gutta percha point and you see I check if the tip of my gutta percha point is covered in sealer. That means that I put it correctly into the root canal, and then I arrive with all of the gutta percha points that I need. In extremely large or oval canal, if you want to use this technique, you can choose a master cone and some accessory gutta percha point in order to reduce the amount of sealer inside of the root canal. And then with my heat carrier, I'm going to just cut the part of the gutta-percha point that extrudes from the root canal opening. And then I take my plugger and just pack the gutta-percha, which, having been warmed, has become soft. And so it can adapt to the shape of the root canal. I finish packing. I use the bigger part of my plugger, obviously, because I'm in the coronal third. And then with just water and air, I rinse and I try to remove the excesses of the calcium silicate base sealer. And this is our finish, my filling phase. You see, it's extremely easy, it's extremely quick, and then I remove all of the remnants of sealer. And I am ready to restore. So I'm saving a lot of time and I can do the restoration in the same visit, for example. This is another case in which I used the single cone bioceramic sealer technique. Why? Because I have thin, long roots, and so why not? And you see, in the distal canal, I was able to fill a lateral canal. And in the medial, there is a bifurcation. I was able to fill bifurcation. With what? Probably part with gutta-percha, part only with the sealer, but I don't care, because this way my filling is three-dimensional and is adapting to the shape of the root canal. So there's nothing I want more than that. You see, I'm completely in the face of the obturation. So I check the fit of my gutta-percha point. I see it's too long, and so I cut a little bit. And then I put the gutta-percha point inside of the root canal again. This is an extremely important step. I'm sorry I keep repeating it, but it's so important. And so I want you to really mark down this concept. Do the tag back, try and check the fit of your gutta-percha points. And then once I'm done, and once I've finished to check the adaptation, I can go on with my filling. Another case, this was an endoperiodontal lesion, initial periodontal lesion with secondary endodontic involvement. So I did my root canal therapy. Also, the intraoperative X-ray can help you in finding if your gutta-percha point is correct or not. And then I just fill the 4 root canals and do the post-endodontic restoration in the same appointment, which is something that I really love to do if I can. This is a lower premolar, the particular anatomy, because the certain point there is this disc split. In this case, single cone and bioceramic sealer. The preparation is so thin, the roots is so thin that I'm not even trying to fit a heat plugger 4 mm from the working length. I'm going smoothly with my single cone and calcium silicate base sealer. But in other cases, I have the space. So why not? I'm choosing a warm technique. In this case, I use the warm vertical condensation of gutta-percha with a zinc oxide eugenol sealer. How do you know I use the zinc oxide eugenol sealer? Because it resorbed. You see the post-operative, you see the 1 year and the 2 year following up, and you see that in the medial root there is a resorption of the sealer. Zinc oxide eugenol sealer, classic. How do I do it in practice? Well, the gutta-percha point fit works exactly the same. In warm techniques, you might like to cut your gutta-percha point 1 mm short from the working length, because you know that while heating and packing, you will just a little go more down, more apical with your gutta-percha point. And so this is something you can do. And then, in the same way, I dried the root canal with paper points. You can use large paper points in the initial phase if you don't dry the root canal with a cannula. So if you have a lot of liquid inside of the root canal, I suggest you to use larger paper point first and then smaller paper points in order to go and dry really the apical third. And then what do I have to do? I have to deliver a heat plugger to 4 millimeters from my working length. So I have to test which heat plugger because I have different sizes. So I have to take the heat plugger, check it, and see if it fits into the root canal. Then I found it, I mount it on the heater, and I'm ready to go. I put the sealer inside of the root canal system, and then I'm ready to put my gutta-percha points. You see that the gutta-percha points in this case arrives to the working length that I determined, and then I'm ready to do the following step, which is cut the part of the gutta-percha with extrudes from the root canal opening. I use the e-heater and I remove the excess of gutta-percha. Then what do? I take my plugger and I pack the gutta-percha in order to adapt it to the opening of the root canal. You start with the bigger part of the plugger, and then if it's too big you can just choose one size smaller plugger or turn it on the other part. It depends on the size of the canal. And then what do? I have to deliver my heat carrier up to 4 millimeters from the working length. I can do it in a single step. I do like 1, 2, 3, 4, and I stay there and I stop heating. I stay there for 10 seconds because I want to allow my gutta-percha to cool down. And then I apply what is known as separation heat. So I heat again for a couple of seconds and I take my e-heater outside of the root canal. And most of the coronal gutta-percha will come out with my heat plugger. So now I take my hand plugger and pack the gutta-percha in apical direction because I want to ensure the seal. And now I have to backfill. So I take the heat filler, I heat it, I position it inside of the root canal, and then I extrude the gutta-percha. And while I'm extruding the gutta-percha, I take the e-filler outside from the root canal. I will be pushed by the gutta-percha that I extrude into that small space. And then, what do? I have to do it more times if I'm willing to, or if there is not so much space to fill, I can do it just in one time. And then after every passage, I take my hand plugger and I pack. And so I arrive to the root canal opening. And these are some cases that I did with this technique. The case on the left is the preoperative that I received from a colleague that referred this case to me because he just missed one root canal opening, did the perforation and put a thermofill into the perforation. So my tasks were to repair the perforation after having removed the foreign body from the periodontium and then shape, clean and fill because I had to do the retreatment. So this is how I managed the case, and these are the follow-ups at 1 and 2 years. And you see that everything is proceeding in a good way and the lesion healed. In the same way, an incisor, easy, straight canal, no particular curvatures, Why not? I'm using the warm vertical compaction of the gutta percha. I use the zinc oxide eugenol sealer, as you see, and you see that over time it resolved. With some calcium silicate based sealers, it is possible to use warm techniques. And so, from my point of view, this is a good combo because calcium silicate based sealers have excellent antibacterial properties, they promote healing, they are osteoinductive, osteoconductive, and the three-dimensional obturation that we can achieve by heating and packing gutta percha leads us to superior results. And so why not just combining these two techniques? And this is another example in which I use the warm vertical compaction of gutta percha with a silicate-based sealer. And you see the healing 2 years later. And what if I don't have the e-heater? I just have the e-filler and a plugger. Well, I can still obturate with a warm technique by using the coneless or bioconeless technique. What's the difference between coneless and bioconeless? That in the coneless technique I use a conventional sealer, while in the bioconeless technique I use a calcium silicate based sealer. And this is an example of a tooth treated with the coneless technique, so just by extruding the warm gutta percha into the root canal and then packing it. And this is the example of three rooted upper premolars treated with the bioconeless technique. And so what did I do? I did the shaping, the cleaning, and in the filling I inserted some calcium silicate based sealer into the root canal, and then I extruded the thermoplasticized gutta percha into each root canal, and then I packed. I did this on the second premolar, and 1 year later, when I also had to do the root canal treatment on the second premolar, I used the same technique, and this is the follow-up. Another case, just with the e-filler and the plugger. You just extrude one gutta percha into the root canal system and then you pack. Obviously, there are some limitations to this technique because in very large apexes you cannot control the flow of the gutta percha, so you have to limit yourself. I use as a cutoff the apical size 50. When it's bigger than 50, I cannot use the bioconeless technique because I use MTA. And so let's just pick the technique for the case. I hardly ever use carrier-based technique. The only situations in which I find it extremely useful is when the patient doesn't allow me using another technique. For example, in a low compliance patient with maybe some physical or health problems in which I have to do everything as quickly as possible, yeah, maybe I can use a Thermofill, but just in this case. So what is the take-home message of this lecture? First of all, versatility. We need to change our approach according to the clinical case. And we cannot think that by using only one technique, we can treat all the root canal systems because it's impossible. Anatomy is too different from one tooth to another to make us think we can manage every case with just one filling technique. So, in order to cover the broad spectrum of root canal treatment that we have to know at least 2-3 techniques well, and then maybe we can just treat everything. But my suggestion is to choose the filling technique according to the root canal anatomy, considering the aspect that we saw before. So the root, is it straight, is it curved, what is the axis that I have, what is the apical size, etc. So I thank you very much for listening, and if you have any questions, I'm more than happy to answer. So thank you. I hope you enjoyed the video. I saw you did a couple of questions, so I will answer. Dr. Mustafa asked, do we need tag back when obturating with bioceramic sealer? Well, in my opinion, yes, because first of all, I prefer having still most of my recline filling made by Gatapercha instead of using the sealer as a filler. Sealer is just the connection between Gatapercha and the tooth. Uh, and when you just cut the head of your Gatapercha point and then you use your plugger, if the size of your Gatapercha point is too small, you risk to extrude the Gatapercha point into the periodontium, so you have an overextension of your root canal filling. So yes, a tag back is extremely important. And so whether we're using cold or hot techniques, when it comes to putting a Gatapercha point, I think that you should really do the tag back. Also because it depends on what you have in your practice. It depends what you have from the market. But sometimes a get a purchase point size 30 is not size 30. Maybe it's 27, maybe it's 32. So check it because the quality of your root canal filling could depend on that 2 minutes that you spend doing the confit. So I think it's very worth it. And then we have another question. Dr. Vaida asked me about my final rinsing protocol. Well, I really love the fact that you asked about the final rinsing protocol because we start counting how is the volume of irrigant that we use and which irrigant we use from the final rinsing. Because everything we used before, it was a lubricant for the instrument, remove the gutta-percha, remove the pulp remnants, whatever, but it's not really cleaning the root canal. So the final rinse protocol is what Riccardo Tonini and I wrote in the book of the retreatments by Style Italiano Endodontics. So 5 milliliters of sodium hypochlorite, we use it full strength. So if you're using a lower concentration, just try to increase the dose. And we do 1 milliliter and we activate with ultrasonics or sonics. And then again, 5 per root canal. Then you make a passage with sterile water, not saline. Sterile water or distilled water, use whatever you prefer, but not saline because it's going to create a precipitate into the root canal and you don't want it. And then EDTA or citric acid or malic acid, you choose according to what you got. You know that EDTA is going to have a demineralizing action on dentin, but still it works very well against the inorganic component. So 2 milliliters of a chelator, and then you rinse again with sterile water or distilled water. And then you dry and you're ready to fill. Some authors suggest to do a final rinse again with sodium hypochlorite, but I think that it's not mandatory. So our protocol is sodium hypochlorite, then sterile water, then EDTA, then sterile water, fill. I don't think that there are other questions, but if something comes up into your mind in the following days, you just write and I will answer. I will write you. Okay? Thank you very much for listening and I hope you enjoyed it. No, there's a question. Okay. Let me see what the question is. Okay. I was asked about the fact that when I talk about warm vertical compaction of the gutta-percha, I talk about packing and delivering the heat plugger up to 4 millimeters from the apex. How do I prevent the gutta-percha point to come outside of the root canal when I remove my heat plugger? And the answer is tag back. If you correctly check the fit of your gutta-percha point, you don't have this kind of problem. You find this kind of problem when you think your cone is frictioning in the apical third of the tooth, but instead it's probably doing it in the middle third. And so what happens? It happens that when you insert your heat plugger, you heat that part, you remove that part, and so apically your gutta-percha point was not touching against the walls of the root canal. And then it comes outside. It happens sometimes. It happened to everyone in the world, I think, because sometimes we are in a rush and we don't do the confit properly. But please try doing it and check that it's frictioning only in the apical part, and you will not have this problem. Okay, so if there is no other questions, I thank you again. Thanks Fanta for the support to this webinar, and see you next time. Bye bye.